Good evening, everyone. It gives me an immense pleasure to welcome you all to the second half of GynoScope, a collaborative academic initiative brought to you by Dr. Nimbkar and SIMSOG and Assist. GynoScope is a series or unique series envisioned with a singular goal to create a space where young medical minds can come together to learn and grow and question in the field of obstetrics and gynecology. Through GynoScope, we aim to bring you a range of clinically relevant cases, presentations, real-time discussions, quiz learning, and unique formats like Dr. Nimkar's Brain Benders, which have now become a favorite among many of us. Today we have Darshan Praveen Kumar Bhandari and Mohit Jitendra Patil from SIT GS Medical College and KS Hospital, Mumbai, to discuss on fetal pregnancy. We are so grateful for your enthusiastic participation from colleges across the country and for the opportunity to help us build a stronger and more connected academic community. Thank you for joining us today. We look forward for an engaging session ahead. Thank you so much.
Hello, everyone, and welcome everyone to tonight's session. Um, we resume this session after hiatus of a week. There are three sessions that had to be postponed, and we shall let you know when shall they be allotted the dates with due course of time. As of now, the existing dates and uh, the existing dates are going to be followed. And welcome and apologies for the postponement. It just put the schedule a bit out of order. So, Darshan and Mohit, are you ready with the slides?
Yes, sir.
Okay. So, let us begin. All the best. We will be following for everyone who is probably for all those who are attending this for the first time. The pattern that we follow is the presenter shall present the entire case within 5 to 10 minutes. And once everyone has gotten an idea about it, then we shall proceed towards the question and answers. There are a few things that I would like to show or discuss with the help of a few images. At that point of time, I'll be sharing my screen. So, not audible. Is there any problem with the audio? Am I not audible enough?
You are, so we can hear you.
Okay, fine. So, Darshan and Mohit, all the best. Let us begin.
Good evening, all. Today we will be presenting a case on multifetal pregnancy. So, starting with the case, Mrs. P, 33-year-old lady, Hindu by religion, resident of Diva, educated up to 12th, homemaker, belonging to lower middle class by modified post-family classification. She is gravida 1, parity 0, living 0. Her last menstrual period was on 4th of December 2024, followed by in vitro fertilization with day 5 embryo transfer on 24th of December 2024 with previous regular cycles and no OCP intake. Her expected date of delivery is 11th September 2025. Her period of gestation is 35 weeks. She is booked and immunized. Blood group is B positive. History of presenting illness. Patient was apparently all right, attended a regular antenatal visit and was admitted for safe confinement of pregnancy. No history of bleeding per vaginum, no history of leaking per vaginum, no history of abdominal pain, no history of difficulty in breathing, no history of decreased fetal movements, no history suggestive of preeclampsia, that is headache, epigastric pain, blurring of vision and decreased urine output. History of present pregnancy. First trimester. Conception was done by in vitro fertilization with donor sperm and self ova. Due to infertility in male partner, pregnancy confirmed by USG at 4 weeks after embryo transfer. 3 fetuses were detected on USG. Folic acid tablets were started preconceptionally, which were continued during first trimester. No increased frequency of urination. No history of excessive vomiting. No history of fever with rash. No history of radiation exposure. NTNV scan was done, which came up to be normal. Second trimester, 3 antenatal visits were there. Quickening was felt at 5th month. Iron, folic acid, and calcium supplementation was started in 4th month of gestation. 2 doses of TD injections were given. Fetal reduction of single fetus was done at 4th month. Screening for GDM was done. Fetal anomaly scan was done, which came out to be normal. No history of bleeding per vaginum. No history suggestive of preeclampsia. Third trimester, 4 antenatal visits were done. Normal fetal movements were felt. Increased frequency of urination. No history of bleeding PV or leaking PV. No history of pain in abdomen. No history of suggestive of preeclampsia. Menstrual history. Men are at 13 years of age with 28 days regular menstrual cycles, bleeding for 3 days, requiring 3 pads per day, no history of passage of clots or dysmenorrhea. Marital history. Married since 8 years and it was a non-consanguineous marriage. Past obstetric history, no past conception. Past history, no history of diabetes mellitus, hypertension, tuberculosis, bronchial asthma, thyroid disorder or epilepsy. No past surgical history, no history of blood transfusion, no history of sexually transmitted disease. Personal history, bowel movements normal, sleep appetite unaltered, denies addiction, no history of drug allergies. Diet history, patient takes mixed diet, calorie intake present is 1800 kilocalorie per day, recommended is 2360 kilocalorie per day with deficit of 260 kilocalorie per day. 560 kilocalorie per day. Protein intake is present is 31 gram per day. Recommended is 50 gram per day. So protein deficit is 19 gram per day. Diet is calorie and protein deficient. Family history is not contributory. Summary: 33-year-old lady, 33-year-old primary gravida with last menstrual period on 4th of December 2024 with expected date of delivery of 11 September 2025 at 35 weeks of gestation. Conception by in vitro fertilization with day 5 embryo transfer on 24th of December 24 with fetal reduction at 4th month of gestation and currently having twin pregnancy admitted for self confinement of pregnancy. So it was case history taking and over to Mohit for examination.
So, starting with the general examination, patient was examined with due consent and in presence of female attendant. Patient was conscious, alert, and oriented to time, place, and person. Patient was comfortable at rest and was poorly nourished, thin built. Height was of 152 centimeter. Pre-pregnancy weight was 35 kg and pregnancy weight was 46 kg with a total weight gain of 11 kg during pregnancy. Her BMI was 15.14 kg per meter square. In vitals, she was febrile. The pulse was 68 beats per minute, regular rhythm, normal force and tension, adequate volume, and no radial and radiofemoral delay. Blood pressure was 130 over 80 mm of Hg, measured on right arm in sitting position. Respiratory rate was 22 cycles per minute, thoracoabdominal breathing. Bilateral lower limb grade 1 edema was present. No pallor, express cyanosis, clubbing, lymphadenopathy was present. Breast engorgement seen, thyroid examination normal. In obstetric examination, on inspection, abdomen was uniformly distended with umbilicus everted, stria gravidarum and linea nigra were seen. No scars, sinuses, dilated veins were present. Hernial orifices appears to be normal. On palpation, patient was examined in supine position. No local rise in temperature was felt. Fundal height corresponds to 36 weeks of gestation. The symphysial fundal height was 40 centimeter and abdominal circumference was of 115 centimeter. Multiple fetal parts were felt and 2 distinct fetal heads were felt. In obstetric grips, on fundal grip, 2 distinct structures were felt, of which one was hard, globular, and palatable, and other was soft, broad, irregular, and non-palatable. In lateral grips, multiple fetal parts were felt. In first pelvic grip, hard, globular, and palatable structure was felt. In second pelvic grip, hands converging, suggestive of non-engagement. Then on auscultation, 2 distinct fetal heart sounds were heard at distance of 12 centimeter with silent area in between. 130 beats per minute above umbilicus in right hypochondrium and other was 142 beats per minute at left spinal umbilical line, suggestive of twin pregnancy. In systemic examination, the S1, S2 sounds were heard and no murmur was heard. Respiratory system, air entry was bilaterally equal and no adventitious sounds were present. In summary, 33 years old lady, primary gravida at 35 weeks of gestation with history of conception by in vitro fertilization with fetal reduction at 4th month of pregnancy and currently having twin pregnancy, admitted for safe confinement. On clinical examination, bilateral pedal edema was present with no pallor and BP was 130 over 80 mmHg. Cardiovascular system and respiratory system examination were normal. On obstetric examination, over-distended abdomen was seen with symphysial fundal height of 40 centimeter. Multiple fetal parts were palpable. 2 different fetal heart sounds were heard, 130 beats per minute above umbilicus and other 142 beats per minute at spinal umbilical line. So coming to the diagnosis, the 33 years old primary gravida at 35 weeks of gestation with twin pregnancy, not in labor.
Thank you, Darshan and Mohit. That was good history. That was great history taking, in fact. Could you please go back to your first slide? Okay. So in your demographic details, could you tell me what are the significant points with regards to your history or with regards to your case, in fact, of multifetal pregnancy?
So the first factor is the age. Like the she is between the 30 to 35 years of age, so it is considered as significant in terms of multifetal pregnancies. Then the other is the history of in vitro fertilization. As we know that in the cases of in vitro fertilization, then there are more chances of multiple pregnancies.
Okay. You mentioned that she is getting near that age wherein just age becomes an independent risk factor for multifetal pregnancy. Could you tell me why?
At around 30 to 33 to 35 years of age, ovarian reserve decreases. So there is decrease in estrogen levels. So negative feedback on pituitary decreases. So there is increased levels of gonadotropin, which results in multiple ovulations and results in multifetal pregnancy.
Excellent answer. Just one point that it is not your estrogen, but instead your inhibin that reduces from your ovaries, which leads to uninhibited secretion of FSH from your pituitary. So, as he correctly mentioned, whenever there is a female who is having depleting fertility, or basically with age, total number of the ovarian reserve is reducing. So the total number of follicles that will be produced would be lesser. And lesser follicles equates to lesser estrogen, or even better word would be lesser inhibin. So whenever inhibin levels are reduced, the pituitary will try to overfunction so that जितने बचे कुचे ovarian reserve में ovary के अंदर ova है, it will try to stimulate them. So in that case, the FSH secretion naturally increases as a female approaches menopause, which is also why one of the ways of diagnosing menopause is an increased FSH. So with an increased FSH, there is going to be hyperstimulation, natural hyperstimulation of the ovaries, which will lead to multiple ovulation. And in fact, both the ovaries might end up stimulating in the same cycle. This increases the chances of possibility of multifetal pregnancy. But could you tell me by this mechanism, what type of twins are going to be increased?
The dizygotic twins will be increased through this mechanism.
Okay, very good. Dizygotic twins, which will equate to eventually dichorionic, diamniotic twins are going to be increased. Great. Now you mentioned about IVF and day 5 embryo transfer was done. This is something that I personally learned in my post graduation. But could you tell me how do you calculate your EDD when you have the embryo transfer date that is available? Because women who are undergoing IVF often tend to remember their embryo transfer date. They do not remember their LMP. So could you tell me how do you calculate the EDD from your embryo transfer date?
So actually, we add 261 days to the day from the embryo transfer for calculation of the EDD. But we can also the day 5 embryo transfer is 5 days after the ovulation. So it will the after 14 days, that is 19th day after the LMP. So we can minus the 19 day from it, and then through the LMP we can calculate the EDD.
Excellent answer. Brilliant answer. That's a very good answer. So basically, in simpler words, as he mentioned, whenever the female tells you that an embryo transfer was done, you have to ask her, was it a day 3 embryo transfer or was it a day 5 embryo transfer? As a matter of fact, could you tell me which is a better embryo transfer, day 3 or day 5?
Day 5 is a better embryo transfer.
Very good. Day 5 is a much better embryo transfer. So most often we do day 5 embryo transfer, but you would still want to ask her. If not, then you can just look into her file. So remember that after your ovulation, they will transfer your embryo after a certain number of days. It can be day 3 or day 5. So depending on that, if it is day 3, then you would be adding 3 days to your day of ovulation, which happens to be 14 plus 3, assuming that the cycle is of 28 days, and you will have 17th day. So the day embryo transfer was done is the 17th day from your LMP. So you will subtract 17 from that, you will get the LMP, and then you will use the normal Naegeli's formula to get your EDD. Now, there is one question that I have in this scenario. You mentioned that the embryo transfer was done, but this is provided that it is the same cycle in which it was retrieved that the embryo transfer was done. Would this be applicable in cases of frozen eggs or frozen embryos?
In that case, we will consider the day of embryo transfer for calculation of the ADD, because calculating the last menstrual period and will be difficult in that case.
Very good. So it will be irrelevant, I would rather say, to calculate the LMP in a case of frozen embryo or frozen eggs. So that's a very good answer. Great. Now, in the next line itself, you have mentioned that she has regular cycle and no OC pill intake. Why? No, no, in the same slide, the same slide. Yeah. So why have you mentioned OC pills over here?
So upon continued exposure to OCP, when we withdraw the OCP, then the subsequent cycles which occur after the OCP withdrawal are means FSH and LH are increased in that case, and hyper ovulation occurs, means multiple ovulations occur, and there is increased chance of multiple pregnancy.
Very good. Very good answer. That's a great answer. So basically, whenever a female is consuming OC pills, remember the mechanism of action of OC pills is inhibition of ovulation. How does it do that? It does it by increasing your estrogen and progesterone levels in the body. So when your estrogen and progesterone levels are increased in the body, of course, by negative feedback mechanism, your FSH and LH are not going to be secreted. So your FSH and LH gets stored up. Pura pituitary bhar jata hai, anterior pituitary with FSH and LH. So the day you stop giving those OC pills, there's a burst of FSH and LH एकदम भर भर के body में secrete हो जाता है. And because of that, there is hyper ovulation or hyperstimulation of your ovaries in the cycles subsequent to OC pills. In fact, for a lot of women who are having fertility issues, a lot of practitioners, as a first basic thing, give this trial of OC pills for 3 months and then they see if they are able to conceive naturally. If not, then they go ahead with ovulation induction. This is for those patients who are not willing to immediately go for ovulation induction or IVF or IUI. So, this is one way of treating infertility by causing artificial hyperstimulation. Very good answer. So currently her period of gestation is 35 weeks. What do you expect your pregnancy to be? Which type of multifetal pregnancy is this? What is your expectation?
The expectation is it will be dizygotic pregnancy, because
Okay, rather than dizygotic, you can just make it a little better by saying dichorionic diamniotic.
okay, dichorionic and diamniotic
Yeah,
pregnancy.
it is very likely. So, is it possible that you have a dichorionic diamniotic pregnancy from a monozygotic pregnancy?
Yes, if division occurs before the day 4 after fertilization, then it is possible to have
Just be a
dichorionic.
little louder, just be a little louder, just be closer to the mic.
If division occurs before the day 4 after the fertilization, then there are chances of dichorionic and diamniotic embryo.
Very good. Now that you have mentioned about this day of division, could you please tell me what are those days of division and what is the outcome?
Before day 4 it occurs, then it is dichorionic and diamniotic. Between day 4 to day 8, it is monochorionic diamniotic. Between 8 to 12 days, it is monochorionic monoamniotic. And after 12 days, there are chances of conjoined twins.
Very good. So basically, the earlier the split, the more the chorion and the more the amnion. As it gets late, जितना ज्यादा लेट होता है splitting के लिए उतना ज्यादा बच्चा चिपका हुआ रहेगा because there won't be any space to divide. And if the split is occurring after 12 days, that is almost half a month of fertilization, then it is very likely that you're going to have a conjoined twin. Very good. So in your case, that is the reason I told you instead of saying dizygotic, it would be a little better if you say DCDA kind of a twin. Okay. Now that you have mentioned all the risk factors, you have mentioned three major risk factors or of twin pregnancy over here: age, IVF, and OC pills. Could you tell me what are the other etiologies or risk factors of multifetal pregnancy? Mohit, Darshan?
Parity. High
Yes,
parity results in multiple pregnancy.
Be louder. Your voice is not clear.
Parity, sir.
Yes, parity. Why parity?
Because as parity increases, there are chances of multifetal gestations.
Means basically after the grand means after the para 5 there are more chances of having multifetal pregnancies. Then
Why? Could you just
there
tell me why though?
as the age of the patient increases, that can be the reason for that.
Okay, but age is an individual risk factor anyway. Okay, no problem. Just I will tell you the reason after you tell the rest of the factors. You can think. The other one can think until then.
The
Tell me,
next
what are the factors?
race is the one factor. Like in countries like Nigeria, there are more chances of means more incidences of multifetal pregnancies.
Okay, ethnicity. Okay, well, very good. Next, the commonest reason why you are having more multifetal pregnancies nowadays.
The in vitro fertilization is the means reason. Like
What else? What apart from in vitro? In vitro is an extreme end of your artificial or assisted reproductive techniques. Something before that.
consumption of OC pills.
No, you already mentioned
Ovulation
that.
induction.
Oh,
Ovulation induction.
Sushma, kindly do not answer, please. Uh, yes, ovulation induction or the drugs that we use for ovulation induction, like letrozole or clomiphene citrate. So, more so clomiphene citrate. So, basically, the drugs that are used for ovulation induction. Remember, ovulation induction is not going to equate with IVF. Ovulation induction can also be done without anything else. It can also be done with just IUI. It can also be done with IVF. So, do not equate both of them. Okay, fine. And lastly, it is ethnicity and family history. Now, regarding the reason why parity is a risk factor. Hmm. So remember that the reason that we mentioned for OC pills being a reason why there is an increased possibility of multifetal pregnancy after you consume OC pills, the reason was inhibition of ovulation. Now, every time a female gets pregnant, remember that she does not have ovulation. So her entire pituitary is filled with FSH and LH. So more those pregnancies, more those periods of non-ovulation, which is why the same reason that applies for OC pills, non-ovulation is what leads to increased possibility of multifetal pregnancy in higher parity females. Also, the endometrium and ovaries are said to get a lot more sensitized to FSH and LH, which leads to hyperstimulation because of multiple pregnancies. And that is why you will have, after multiparity, possibility of multifetal pregnancy. ठीक है. Next slide. Okay, so no history of bleeding per vaginum, leaking per vaginum. Okay. Could you tell me what are the most common complaints, specific complaints that you find in a female with multifetal pregnancy?
Due to increased HCG levels in first trimester, there are increased chances of hyperemesis gravidarum.
Okay, very good.
Uh,
So because of higher HCG levels, because of a larger placental mass, you will have more HCG in the body, and more HCG is going to stimulate your chemotactic receptor zone. And okay, next.
Due to over distended abdomen, there is difficulty in breathing that will come in later trimesters. So, uh,
Yes, very good.
uh, bleeding per vaginum due to there are increased chances of antepartum hemorrhage as placenta is weak. There are increased chances of placenta lying in the lower uterine segment. So there is increased chances of placenta previa. Also, there is
Okay, why would you find placenta in the lower segment or in the at the bottom of the uterus? Any particular reason?
because of large placenta, sir.
Large placenta, also because of crowding of the uterus, the placenta is not able to migrate to the upper segment. So it gets stuck over there because of the fetuses and because of course, the larger placental mass, it is unable to migrate. Trophotropism में problem आ जाता है. Okay, very good. What else?
There are there are chances of polyhydramnios and preeclampsia. So due to which there are increased chances of antepartum hemorrhage, which can also result in bleeding per vaginum. There are increased
Okay.
chances of preterm pre-labor rupture of membrane, so it can lead to leaking per vaginum.
Okay, wait. There are two things that you mentioned, polyhydramnios and preterm labor. Could you first tell me the causes of polyhydramnios in twin pregnancy?
In twin pregnancy, since there are two fetuses, there will be urine will be produced by two fetuses. So there were increased urine production, which can result in polyhydramnios. Another
Okay,
reason,
very good. One is going to be double दोनों का मिला के जो भी amniotic fluid है वो. Yes, first reason. What else?
another reason being placenta, as placenta is big, which can result in larger surface area and larger transudation can occur.
Excellent answer. Very good answer. In the first 20 weeks, your placental transudation is a major mechanism of production of liquor. Very good. What else?
Fetal skin also double, so two fetuses too.
Okay, fine. What else? Some complication wherein you will find poly.
Twin to twin transfusion syndrome can result in.
Very good. Twin to twin transfusion syndrome. We'll come to that later. But yes, twin to twin transfusion syndrome is yet another cause. Very good. Um, Anything else that you can think of more so in monochorionic pregnancies? Elderly female monochorionic pregnancy, anything that can lead to polyhydramnios?
There are also increased chances of diabetes mellitus due to increased production of human placental lactogen, which can result in
Very good, very good. So increased polyhydramnios के chances, diuresis ज्यादा होगा because baby में glucose ज्यादा आएगा, so glycosuria, diuresis बहुत होगा. Very good. What else? Monochorionic increasing age. I'm giving you two big hints for polyhydramnios in twins. Increasing age, increased chances of aneuploidies like trisomy और any other anomalies जिसमें swallowing defects आ सकते हैं, atresia हो सकता है, duodenal या फिर esophageal. That is going to impair the ingestion of the fluid, which is why anomalies and aneuploidies increase with increasing age. In monochorionic twins, the chances of these aneuploidies and anomalies are even higher, which will eventually lead to polyhydramnios. So increased chances of anomalies. ठीक है? So next is preterm labor. Why preterm labor?
So there is over distension of the uterus, which can lead to uterine irritability, which can result in preterm labor.
Okay, very good. So uterine stretch, increasing uterine stretch. What else apart from that? Polyhydramnios in itself is the reason why you can have preterm labor.
Preterm pre-labor rupture of membranes can also result in that.
Yes, correct. Very good. So you have mentioned about over distension, preterm labor. You have mentioned about hyperemesis gravidarum. You have also mentioned about increased chances of preeclampsia. Um, any other chances? Any other? You have mentioned bleeding per vaginum. Why have you mentioned that?
Antepartum hemorrhage chances are more. So bleeding
Why?
per because as there is large size of placenta than placenta previa than abruptio placenta, these chances are more. So
Very good, very good. So the chances of individual causes of antepartum hemorrhage are more, which is why it can lead to bleeding per vaginum before time. Okay. History of difficulty in breathing and history of decreased fetal movements and no history of preeclampsia. Very good. ठीक है. Next slide. So it was donor sperm and self ovum. Now I have a question that may not necessarily be with regards to multifetal pregnancy. It is just with regards to IVF. Could you tell me what are the reasons, what are the side effects of IVF on a female? Just a brief discussion.
as we use the induction methods in IVF like clomiphene citrate and letrozole, the drugs can cause side effects in the female and
Okay, like side
hyperstimulation of,
effects like,
hyperstimulation of ovary.
okay, what is it called as? The syndrome?
Ovarian hyperstimulation syndrome.
Very good. So OHSS chances are high. What else?
There are increased chances of multifetal pregnancy.
Okay, very good. What else? think from the point of view of you having a donor sperm, and just think of it, if you also have a donor egg, what will happen?
So as there is the foreign antigens are more, then there can be more chances of preeclampsia and other means autoimmune causes of fetal rejection.
Very, very good. That's a great answer. So increased chances of fetal growth restriction, preeclampsia, if both donor sperm as well as donor ovum होंगे तो. Also remember that if you're using frozen eggs or if you're using a donor egg, in that scenario, the female is not going to have her own corpus luteum. Now, corpus luteum secretes relaxing hormone. And that relaxin hormone is useful in vasodilatation, which also helps in the dilatation of spiral arterioles. So if you do not have a corpus luteum and you hence don't have relaxin, your uterine vasculature is not going to be dilated. The perfusion of the uterus and the placenta eventually is going to be lesser, and that is going to predispose to preeclampsia and fetal growth restriction. So that is another complication that will happen because of donor sperm, donor egg, and a frozen cycle if you're or like frozen embryo if you're going to be using it at some point. ठीक है. So it was confirmed by USG after 4 weeks. 3 fetuses were diagnosed and folic acid was started. Okay. Now 3 fetuses were detected. You have mentioned आगे जाके that there has been reduction that has been done. Could you tell me what is the ideal time for fetal reduction, ideal gestation?
So fetal reduction is generally done at 11 to 13 weeks of gestation,
Yes, why?
because up to 10 weeks there is a process of natural selection. If there is any aneuploidy detected in the fetus, which can be rejected by the mother's body itself. So if
Excellent answer. Very good. Very good. What else?
at 11 weeks we can do USG and then see any markers are there. If NTNB scan, after which anomalies, if detected, we can select the fetus for the reduction.
Excellent answer. So 11 to 13 weeks is an ideal time, 11 to 14 weeks in the rather, because first of all till 10 weeks all your normal aneuploidies जो भी है body उसको detect करके खुद ही खत्म कर देगा. And secondly, you will also do an NT-NB scan, and the fetus with the least crown rump length, or the fetus with increased nuchal translucency, or the fetus with abnormal nasal bone or an absent nasal bone to be more specific, or any other anomaly that you can see, that is the fetus that is more likely, or that is a fetus that is more likely to die anyway, and hence we will reduce that. But what if you are doing a fetal reduction and all the 3 fetuses are normal? Then how do you choose which fetus to terminate?
Sir, first of all, we do USG and by NTNB scan, we do a numerical translucency. If it is normal, then we see crown rump length.
Everything is within normal length. Everything is within normal limits.
Yes.
How do you
So
proceed?
fetus is away from the cervix is taken for that.
Okay, assume कर ले कि there are 2 fetuses that are near the cervix. या फिर all of them have literally implanted equidistantly. So
So then
cervix वाला factor थोड़ा difficult हो गया.
So then we can see the chorionicity of the means. If we have to reduce dichorionic twins mainly.
Yes, correct. So could you just tell me a little more about it? Assume कर ले तेरे पास TCTA है, ट्राइकोरियोनिक ट्राइएमनियोटिक. तो उसमें तू किसको करेगा रेड्यूस जो सर्विक्स से सबसे दूर है, बिकॉज दैट इज द इजीएस्ट चॉइस टू मेक.
Yes.
पहली बात, ये जो सर्विक्स वाला पॉइंट है इसे तूने क्यों बोला? व्हाई शुड इट बी अवे फ्रॉम द सर्विक्स?
Sorry, if it is near the cervix, then if after fetal reduction, fetal will be dead, and body has natural tendency to means expel the fetus. So there are chances that that other two twins, which are two babies which are normal, can also be expelled, and there will be abortion. And
वेरी गुड, गुड
point is
आंसर, ग्रेट आंसर,
fertility.
करेक्ट आंसर, वेरी गुड. ठीक है. सो नाउ यू हैव सेकंड सिनेरियो, DCTA. DC इज डाइकोरियोनिक ट्राइएमनियोटिक ट्विंस. अब किसको रेड्यूस करेगा?
So monochorionic monoamniotic twin near the cervix will be chosen in this case.
सर्विक्स का बात छोड़ दे, जस्ट डोंट कंसीडर द सर्विक्स फैक्टर नाउ. यू हैव DCTA ट्विंस. एक
Monochorionic
है.
amniotic twin will be selected.
वेरी गुड. सो द वन जिसका खुद का अलग से प्लासेंटा है और खुद का अलग से एमनियोटिक फ्लूइड है, उसको तू रेड्यूस करना प्रेफर करेगा, एंड यू वुड लीव बिहाइंड अ मोनोकोरियोनिक डायएमनियोटिक प्रेगनेंसी. करेक्ट?
Yes, sir.
ठीक है. बट नाउ आई एम द कपल जिसके लिए तू एज एन ऑब्स्टेट्रिशियन रेड्यूस करके दे रहा है. आई एम अ वेरी एजुकेटेड पर्सन जो तेरे पास आया है एज अ पेशेंट, एंड आई आस्क यू कि सर आप मेरे बॉडी में एमसीडीए ट्विन छोड़ रहे हो, और मैंने पढ़ा है कि एमसीडीए में ये ट्विन ट्विन ट्रांसफ्यूजन सिंड्रोम होता है, टीएपीएस होता है, ट्रैप होता है। सो मेरे के अंदर जो प्रेगनेंसी छोड़ रहे हैं उसके भी तो कॉम्प्लिकेशन हो सकता है। ऐसे भी तो हो सकता है कि वो दोनों में कुछ तो कॉम्प्लिकेशन आ जाए और वो दोनों भी खत्म हो जाए। एंड आई एम ऑलरेडी 40 year old, माई वाइफ इज 40 year old, so I've used up all my money as well, so this is my only chance of having a pregnancy. What do you do in this scenario?
Sir, we can then select MCDA also and resulting in single pregnancy then. We will
Yes, very
but-
good. Excellent answer. So basically, it all depends on your communication with the patient. You have to ask them how many twins do you wish to keep behind, or how many babies do you wish to keep behind. Because remember that twin pregnancy can also be a financial burden for them, and they may not be financially ready or adept at having two babies. So you can also give them the option of reducing two babies instead of one, but tell them that since I'm reducing two and keeping just one inside, there's a possibility that the third baby might also abort or might have some problem later on. So you have to be careful that if you're just keeping one baby, अगर उसमें कुछ हो गया तो प्रॉब्लम आ सकता है, बट अगर प्रॉब्लम नहीं आया तो इट विल ग्रो एज अ सिंगलटन ट्विन व्हिच विल हैव द बेस्ट पॉसिबल चांस ऑफ सर्वाइविंग। ठीक है, यू मेंशन्ड कि जो मोनोकोरियोनिक है, मतलब मोनोकोरियोनिक डायम्नियोटिक वाला है ट्विन, उसको तू रेड्यूस नहीं करेगा, व्हाई?
So basically, there are connections between the monochorionic fetuses, like the superficial and deep connections between arteriovenous, or veno-venal connection. So if we in fetal reduction procedure, we actually introduce a KCL injection in the heart. So the KCL can transfer from one fetus to other and will cause abortion of the other two. So
Will cause death of the other twin, death of the other twin.
death of
Very
the
good. सो बेसिकली मोनो अगर सेम प्लासेंटा है एंड यू हैव टू एमनियन, वो दोनों एक दूसरे के बीच में केसीएल एक्सचेंज हो सकता है, एंड प्रॉब्लम आ सकता है कि दोनों फीटसेस के अंदर केसीएल चला गया थ्रू द कनेक्शंस, एंड इनवेरिएबली दोस कनेक्शंस आर ऑलवेज देयर। यहां से आते हैं मेरे दो इंपॉर्टेंट क्वेश्चन। सबसे पहला मेरा इंपॉर्टेंट क्वेश्चन है, KCL is one method that you mentioned. Are there any other methods of termination, fetal termination?
Sir, so there are two methods. First of all, there are two lifelines, means umbilical cord and heart of the fetus. So we can ablate the umbilical.
Be louder, just come closer to the speaker.
There are two options. We can inject KCL in heart of the fetus, or we can ligate the umbilical cord, cutting off the blood supply of the fetus. So umbilical cord is very thin, around 11 to 13 weeks. So we prefer KCL in first trimester. So
Very good.
radio frequency ablation of umbilical cord is generally preferred in late, means in third trimester, because if other fetus is dead, then it can result in preterm labor of the other two. So after giving corticosteroid cover, we do this procedure in third trimester.
Excellent answer. Lovely answer. That's a great answer. Now there's a question for you. What is the difference between fetal reduction and selective termination? It's not fetal termination, it is selective termination. Could you tell me what is the difference?
So fetal reduction is done. So fetal reduction is done between 11 to 13 weeks. That is late first trimester or early second trimester. Selective
Yes.
termination is done after anomaly scan. If anomaly is detected in late second trimester or early third trimester.
वेरी गुड। सो बेसिकली जितना बड़ा फीटस है उसको हम लोग बोलते हैं एसटी, दैट इज सिलेक्टिव टर्मिनेशन, वेयर जो अर्ली वाला है हम लोग उसको बोलते हैं मल्टी फीटल रिडक्शन, दैट इज एमएफआर। सो सिलेक्टिव टर्मिनेशन इज व्हाट यू डू इन एन ज्यादा बड़ा वाला फीटस जो रहेगा, थर्ड ट्राइमेस्टर वाला जो रहेगा, फॉर सम और द अदर एनोमली दैट यू हैव डिटेक्टेड लेट, या फिर फॉर सम कॉम्प्लिकेशन दैट यू हैव डिटेक्टेड जो लेट डायग्नोस हुआ है, उसको कहेंगे सिलेक्टिव टर्मिनेशन। ठीक है, नाउ कम्स माय सेकंड क्वेश्चन। यू मेंशन्ड अबाउट दोस कनेक्शंस एवी एए वीवी। So could you tell me what are the complications that these connections can lead to? Very, very important question.
So the first complication is twin-to-twin transfusion syndrome. Then the second is TRAP, that is means transarterial
Twin reverse arterial perfusion. Then there is twin anemia polycythemia sequence and selective fetal growth restriction are the four complications.
Okay, so could you tell one by one what are each one of them? I will also explain after you're done with the help of a few images. So could you just start with twin-twin transfusion syndrome?
In twin-to-twin transfusion syndrome, there are arteriovenous and veno-venous communication, of which arteriovenous communications are most important. In this, there are unidirectional flow of blood from one fetus to another fetus. So there is volume overload in one fetus, and there is decreased blood in another fetus, donor fetus rather. So the donor fetus develops anemia, oligohydramnios, and receiver fetus develops polycythemia, thrombotic complications, and polyhydramnios. So, for its diagnostic criteria is monochorionic diamniotic twin. First criteria. Second is oligohydramnios in one donor and polyhydramnios in recipient twin.
Okay, very good. So could you tell me what is the classification or what is the staging that they do to know how severe it is?
Quintero staging is done for this twin-to-twin transfusion syndrome.
Okay, could you tell me what is this twin to twin or rather what is this Quintero? एक step by step बता सकते हो?
Yes. In first, there are polyhydramnios in first twin and oligohydramnios in other with bladder visible and Doppler normal. In second, polyhydramnios in one twin, oligohydramnios in other, bladder not visible and Doppler being normal. In third stage, there is Doppler is abnormal. In fourth stage, there is heterospitalis in one or more one or two twins. In third, there is death of one fetus on stage 5.
Okay, very good. Could you tell me what is the management for this?
In first and second, we can do radio frequency ablation for connections. In fact, all we can do radio frequency ablations to destroy the connections. And we have to deliver it at 34 to 36 weeks.
Okay, very good. What is the name of the technique that we use?
Solomon technique is used with radio frequency ablation in the equatorial plane.
Yes, very good. Good answer. So now I'll just turn on my notepad for 2 to 3 minutes and I'll explain each and every individual complication. Fine. I'll just present my own screen now. Okay. Is my screen visible? Okay. Is my screen visible now? Mohit, is my screen visible?
Yes, sir. Yes, sir.
Okay, fine. So now there are multiple complications that are going to be seen. So उसमें से सबसे पहले तो we are going to be talking about twin transfusion syndrome that you can see over here, for which Quintero staging, as Darshan and Mohit correctly mentioned. So there are 5 stages, 1 से लेके 5 तक है, 1 being the best possible outcome and 5 being the worst possible outcome. Basically, the fetuses have died. But before I understand what is this, I would like to mention कि ये क्या होता है. Now here is a very simple image that you can see. This is the intertwining membrane, दोनों के बीच का जो membrane है. और यू कैन सी यहाँ पे देर इज वेरी इजीली विजिबल ओलिगोहाइड्रामनियोस और यहाँ पे बहुत ही इजीली विजिबल पॉलीहाइड्रामनियोस है. सो व्हाट हैपेंस इज यू नो that you have your umbilical artery that takes the blood from the fetus to the placenta, and you have your umbilical vein which gets the blood from the placenta to the fetus. So whenever there is going to be a connection between these two, the blood that is coming from the umbilical artery, which happens to be the deoxygenated blood from one fetus, is going to go into the umbilical vein of the other fetus and is going to perfuse the fetus. So what happens is I'm going to now have 2 twins. One is going to be my donor twin and one is going to be my recipient twin. So donor twin through its umbilical artery is giving blood, that is deoxygenated blood दे रहा है एंड वो ब्लड देते जा रहा है. वेराज ये जो रेसिपिएंट ट्विन है ये उसको ब्लड डीऑक्सीजनेटेड मिलते जा रहा है टू इट्स अम्बिलिकल वेन. तो इसकी वजह से क्या होता है, डोनर ट्विन के अंदर का जो ब्लड है खुद के बॉडी का, इट कीप्स ऑन गोइंग लोअर एंड लोअर. सो द अमाउंट ऑफ ब्लड इन द डोनर ट्विन कीप्स ऑन रेड्यूसिंग. सो व्हेनेवर द बेबी, द डोनर ट्विन जो है उसके अंदर कम होने वाला है खुद का ब्लड, whereas ये जो रेसिपिएंट है उसके अंदर खुद का ब्लड बढ़ने वाला है. Now, because there is less blood in one of the fetuses, the body will try to reduce the blood supply to the non-important organs and will shunt the blood to the important organs like the heart, adrenal, and the brain. This will lead to reduction in the urine output because kidneys are going to be sacrificed. So that leads to oligohydramnios in the donor twin. Whereas this baby के अंदर the blood was more, in that scenario, you will see that the baby, because of excessive blood, it is trying to push out all the excessive blood that is coming inside it. That will lead to polyhydramnios. ये जब होगा तब मुझे पता चलने लगेगा कि मैं स्टेज 1 पे आ चुका हूं क्विंटेरो स्टेजिंग के. स्टेज 1 is still something that can give me a good outcome, but this does not stop here. After a point of time, the heart of both the fetuses starts feeling the pressure. एक में बहुत ही कम blood है, it has to work extra to pump थोड़ा बहुत जो blood बचा है into the body, whereas the other heart has excessive amount of blood. There is cardiac overload and it doesn't know what can I do with it. So both the twins are eventually going to have heart failure. एक को होगा because of less blood, एक को होगा because of extra blood. This heart failure is going to be called as hydrops fetalis. This eventually will lead to death of one or both the twins. Eventually, basically, both the twins are going to die, but this is going to be the process. So how do I stop this process from going ahead? So ये जो connection है, AV वाला connection, I use Solomon technique to cut down this connection. Solomon technique is basically, if this is my placenta and if these are the connections that are going between them, I use a razor or I use a radio frequency ablation machine to equatorially cut off all these connections between the arteries and the veins. ये जब कट होंगे तो ये ब्लड सप्लाई एक दूसरे के अंदर का बंद हो जाएगा. But now there is a problem. Whenever you cut off any vessel, that vessel will start developing collaterals. छोटा 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 collaterals develop शुरू होना होगा. And then there will be tiny vessels that will start developing between both of them. Now these tiny vessels are not permitting the flow of blood, but they are permitting the flow of a few cells. So RBCs keep on passing from one point to the other one. So now your donor twin and your recipient twin के बीच में there will be RBCs that are being sent. So RBCs जब भेजेगा तो एक बेबी का RBCs कम हो रहा है इसलिए उसमें होगा अनीमिया एंड दूसरे बेबी में होगा पॉलीसाइथीमिया. This is called as twin anemia polycythemia sequence or syndrome, TAPS. Hence, TAPS is most commonly a result of the complication of the treatment that has been done for TTTS. It can also develop spontaneously, but it is less likely. It is more likely that it is going to develop as a complication of the treatment that was done for TTTS. Similarly, वो दोनों में एक में अलीमिया होगा, दूसरे में पॉलीसाइथीमिया होगा. उसके वजह से जो अनीमिया है, because of lack of cells, the blood का velocity is going to increase because of lesser viscosity. Whereas in the polycythemia, because of increased viscosity, the velocity will go down. Now, because of this, the MCA PSV, that is the middle cerebral artery peak systolic velocity जो है वो ज्यादा आएगा. Whereas इसके अंदर जो middle cerebral artery का peak systolic velocity है वो कम होगा. So the diagnostic criteria is going to be MCA PSV more than 1.5 MOM, the way we have learnt in our RH isoimmunization, and इसमें it is going to be less than 1.0 MOM. This is diagnostic of TAPS. That is, whoever this is, kindly mute, please. So the way I am going to diagnose TAPS is going to be by looking at the middle cerebral artery peak systolic velocity. Again, the treatment is going to be to do a repeat Solomon technique से radio frequency ablation along the center of my placenta, equatorial distribution. This was about twin-twin transfusion syndrome and TRAP. Now, Mohit and Darshan, I have a question for you. Could you tell me how would you manage, if not for this way of managing, ये equatorial जो method है वो अगर नहीं करना है Solomon technique से, what are your alternative methods of managing twin-twin transfusion syndrome? What if the female is having problems with breathing and all, जैसे polyhydramnios में होता है? So what are your alternative methods?
So another method is amino reduction. In polyhydramnios, we can reduce the volume of we can reduce the volume of amniotic fluid. And another technique is septotomy. We can means there is oligohydramnios and polyhydramnios in other twins. So between the membranes, we can make a hole and make the amniotic fluid transfer. But this is not a definitive treatment for this.
वेरी गुड. सो बेसिकली आई जस्ट क्रिएट अ होल बिटवीन बोथ द फीटसेस एंड वो एक दूसरे के अंदर अपना फ्लूइड, उनका जो एमनियोटिक फ्लूइड है वो ट्रांसफर होगा. ठीक है. कुड यू टेल मी, इज दिस कॉम्प्लिकेशन मोर कॉमन इन एमसीडीए और एमसीएमए?
It is more common in MCDA twin.
Very good. Why not in MCMA?
In MCMA, there are deep connections, no deep connection existing.
No, ulta, deep connections दोनों में है, but MCMA will also have a few superficial connections that will negate the flow. वो neutralize कर देंगे.
Yes,
तो MCMA के अंदर the chances are low, नहीं होगा, लेकिन chances काफी कम होने वाले हैं of this happening. ठीक है. Now we have spoken about twin transfusion syndrome and TAPS. Could you tell me what is TRAP? Twin reverse arterial perfusion.
In twin reverse arterial perfusion, there is arterioanastomosis, in which the another fetus is acardiac, means there is no heart tissue developed. So the deoxygenated blood from the living the good twin goes to the acardiac twin in the IVC, supporting the lower part of the body. So it results in the cardiac acceptance.
Very good. So in TRAP, that is twin reverse arterial perfusion, you have one donor twin and you have a recipient twin again, but the recipient twin here does not have a heart. A cardiac twin है वो. तो अभी हार्ट नहीं है तो क्या होगा? इसके अंदर होगा पूरी तरह से नेगेटिव प्रेशर. नेगेटिव या जीरो भी प्रेशर बोल सकते हो तुम लोग. Now there is an arterio-arterial connection. In twin transfusion syndrome, it was arteriovenous connection. यहाँ पे there is an arterio-arterial connection. So क्या होता है? इसके arteries का जो pressure है, वो नीचे आएगा donor twin से, इसमें से जाएगा and it will push the blood back into the umbilical arteries and it will go back to the body of the recipient twin. Now remember, it is an arterio-arterial and not arteriovenous. And umbilical artery is a branch of the internal iliac artery from the common iliac. So when this reversal is happening, as the name suggests, twin reversal arterial perfusion, ये उल्टा जाएगा और back to the iliac arteries जाएगा. और iliac के जो branches है, वो external iliac भी है, which will only supply the lower limbs. Which is why in this fetus, the acardiac twin, the lower limbs are going to develop because of the reversal of flow, which is going to go back into the iliacs and then to the femoral arteries and then to the lower limbs. Hence, थोड़ा बहुत जो भी blood आ रहा है deoxygenated from the donor twin is going to go and accumulate in the lower half of the body. Hence, these twins are also called as acardiac, acephalous. Acephalous मतलब उनको head develop होता ही नहीं है, सिर्फ lower limbs develop होते हैं, या फिर कभी कभार तो लोअर लिम्स भी नहीं होते. देयर इज जस्ट एन amorphous mass that is present because nothing could develop, but the head is mostly absent, which is also why we call this acardia, acephalous sequence. The head, वहां तक ब्लड जाएगा ही नहीं because the pressure is not letting the blood go to the ऊपर का side of the fetus and hence only the lower limbs develop in trap sequence. Again, the method of management is going to be the same to cut off these vessels. ठीक है. Now these were two important complications. Now there is one more thing that we call as the SGR, that is selective growth restriction. Before we go there, Mohit, Darshan, could you tell me what is discordance in twins?
Sir, can you repeat the question?
What is discordance?
Achha, the discordance is basically there are criteria for discordance. There is a difference of 25% fetal weight in both the twins. Then it is called a discordant twins. Or there can be a difference of 20 mm of the abdominal circumference. Or there can be difference of 5 gram% of hemoglobin between them. And 5% of the head circumference difference can be present in the discordant twins.
Very good. So you have mentioned about the three criteria जिसमें discordance हो सकता है. So what is discordance? Simply speaking, both the babies are not growing equally. एक छोटा है, एक बड़ा है. Usually, whenever the difference between both the baby weights is 20% or more, we call it discordance. Now, could you tell me what is the difference between discordance and selective growth restriction?
In discordance, there is difference in the growth of both the twins. Means there might be that one twin is not, both the twins are not growing, but there is difference in both the twins. In selective fetal reduction, only one fetus is not growing appropriately.
Um, there is a little bit of a difference between what you have mentioned. So basically, दोनों SGR में और discordance में there is effective fetal weight में 20% का weight difference. So 20% का weight difference दोनों में है. But discordance में the Dopplers are normal. ये N जो है वो normal है मेरा, मैं normal वैसे लिखता हूँ. Whereas in SGR, one twin, the smaller twin is going to have abnormal Doppler. So basically, it is fetal growth restriction of one twin. Selective growth restriction का मतलब है fetal growth restriction of one twin wherein there are going to be Doppler changes. So the criteria to diagnose it has been given over here. So how do I diagnose that there is SGR? So सबसे पहले तो effective fetal weight of one fetus is less than third centile or two of the following three parameters. The first parameter being effective fetal weight discordance of more than 25% or effective fetal weight or abdominal circumference of the smaller fetus less than 10 centile, and the third one being umbilical artery Doppler of smaller fetus is abnormal. That is basically umbilical artery PI is more than 95th centile. So if any two of these three criteria are fulfilled, then I will put that under SGR. Could you tell me what are the stages or types of SGR?
In type 1 of SGR, there is a growth restriction of one twin, along with there is positive end diastolic flow. In type 2,
Yes, correct.
there is discordance with absent or reversal of end diastolic flow. In type
Very good.
discordance as well as cyclically. Sometimes it will be negative, absent, or positive.
Very good. So could you tell me which is going to have the best possible outcome in all these types?
First will be having the best outcome.
Best outcome, and for third is going to have the worst outcome. So when will you deliver each one of these?
Type 1 can be delivered at normally 35 to 36 weeks, and type 2 and 3 is generally delivered at 32 to 34 weeks.
वेरी गुड. सो 32 वीक्स के पहले डिलीवर करना है अगर 2 और 3 एक साथ है, और अगर 1 है तो 34 टू 36 वीक्स तक डिलीवर करना बहुत जरूरी है. एंड हेंस एज परफेक्टली आंसर्ड, आई विल बी वेरी ऑनेस्ट, दर्शन, मोहित, हु इज द वन हु इज आंसरिंग बाय द वे?
So this is Mohit.
Sir, I am
Okay.
And this
So the thing is, in my undergraduation, I honestly didn't understand all these things. And the way you have explained, I'm pretty sure most PGs also would struggle who have not read to answer this. So you have answered brilliantly all these complications. And these are the four major complications of monochorionic twins that you are going to find. And in your exams, you can take a screenshot. This is from the latest Green Top guideline. Amazingly answered. Highly impressed. Very good. Good answer. So I'll stop sharing my screen so that you all can now share your screen. So just share your screen again. Okay. So before we proceed, has everyone understood all the complications? And is there any doubt? Has everyone understood it properly? Tab tak you can just go on to the next slide. Okay. So second trimester, 3 antenatal visits. Quickening was felt in the 5th month. Iron folic acid was given. And fetal reduction was done. Okay. So could you tell me what are the outcomes of fetal reduction? कैसे रहता है फर्स्ट ट्राइमेस्टर में? अगर फर्स्ट 10 वीक्स में गया तो क्या रहेगा, नेक्स्ट 10 वीक्स में गया तो क्या होगा, और आगे जाके क्या होगा?
So if there is reduction in first month, then there can be a vanishing twin can be present. Then in second trimester, there can be fetus papyraceous present on compresses.
वेरी गुड. सो
Then
करेक्टली सेड, फर्स्ट ट्राइमेस्टर में अगर हुआ फर्स्ट 10 वीक्स में तो इट इज कंप्लीटली गोइंग टू गेट एब्सॉर्ब्ड, वैनिशिंग ट्विन होगा. बिटवीन 10 टू 20 वीक्स में अगर हुआ तो इट इज गोइंग टू स्टे एज अ पेपर थिन बेबी which is compressed on the walls of the uterus. It is going to be fetus papyraceous. And what will happen if it is there in the last 2 weeks of last 2 और लास्ट 20 weeks ऑफ जेस्टेशन अगर उसमें अगर होता है फीटल डिमाइस तो क्या होगा?
If it occurs in last trimester, so there will be so the life fetus, life fetus becomes the high pressure system and other becomes the low pressure system. So upon transfer of blood to the low pressure system, there will be ischemia in the living fetus, which can result in neurological complications in the living fetus, such as cerebral palsy, porencephaly, multicystic encephalomalacia, etc.
Very good answer. So basically, whenever one fetus dies in monochorionic twins, in dichorionic it is okay, but in monochorionic, whenever a fetus dies, remember those connections जो है vessel के, the fetus which dies, the heart has stopped pumping, so it has become a zone of zero or negative pressure. So the other baby is going to immediately start pumping its own blood to the other twin, and hence the living twin is going to have a state of immediate hypotension. The second the baby has died, it is going to have hypotension. That hypotension is going to lead to ischemic brain damage and porencephaly, as he has mentioned. Basically, white matter में there are going to be pores that are going to be formed. Apart from that, cerebral palsy का risk बढ़ता है. So all these risks are going to also start affecting the live fetus. How do you know whether these things have happened in the live fetus?
We can do MRI in the after the means
After the fetal demise of other fetus.
Correct. Very good. So monthly MRI करना बहुत जरूरी है to look at the changes, neurological changes in that fetus. So that is one thing. And when will you deliver this? एक twin अगर demise हो गया तो कभी deliver करोगे? And will you monitor something else as well in the mother?
So it can cause increase in chances of DIC in the mother. So we
Yes,
have
very
to
good.
means monitor the fibrinogen and other means blood coagulation profile of the mother. And
Very good. INR APDT you will monitor. Weekly monitoring करोगे. Also sepsis के chances है. So एक CRP या at least CBC counts देखोगे कि sepsis कुछ बैठ रहा है या नहीं. WBC counts are enough. Good. You will deliver ये कब तक deliver करेगा तू?
32 to 34 weeks we should deliver the fetus. Means.
A lot of guidelines say कि 36 plus 6 तक भी खींच सकता है अभी. 2024 का गाइडलाइंस कहते हैं मैं तो खुद 34 तक ही खींचता हूँ, बट द लेटेस्ट गाइडलाइन से कि 37 तक यू कैन स्टिल पुल इफ द ब्रेन डैमेज इज नॉट येट सिग्निफिकेंट इनफ. बट ठीक है, दैट इज फाइन. तो फीटस एक अगर डिमाइस होता है तो सो नाउ हाउ आर यू गोइंग टू मॉनिटर योर मोनोकोरियोनिक प्रेगनेंसी? हाउ फ्रीक्वेंटली?
In monochorionic pregnancy, we have to do USG after 16 weeks of pregnancy every 2 weekly.
Very good. What are the parameters that you're going to monitor? There are 4 of them. Which 4?
Umbilical artery Doppler we have to do.
For what indication? Umbilical artery PI क्यों करेगा? To look for SGR. SGR RI की नहीं देखने के लिए umbilical artery PI देखेगा. ठीक है. Next.
Ductus venosus we can monitor.
No. 4 very important tests. Ultrasound पे.
Sir, anomaly scan.
No, it is something you have already done. Every 2 weekly क्या क्या करेगा?
Amniotic fluid index for polyhydramnios.
Yes, very good. Amniotic fluid index you will check. What
Fetal
else?
biometry for estimated fetal weight.
What did you say?
Fetal biometry.
Very good. Effective fetal weight. Discordance है कि नहीं देखने के लिए. Very good. And one more. MCA PSV
Yes.
to check for TAPS. TAPS अगर आ रहा है कि नहीं, TAPS हो रहा है कि नहीं देखने के लिए, you will also check for MCA PSV. So the 4 tests that you will do is umbilical artery PI to look for SGR, MCA PSV to look for TAPS, AFI या फिर single deep vertical pocket to look for twin transfusion syndrome, and lastly fetal weight to look for discordance or SGR या फिर even TTTS अगर आ रहा है कि नहीं. So these 4 tests have to be done every 2 weekly, right from your 16 weeks of gestation till your 36 weeks when you deliver these babies. ठीक है. So in your case, the second trimester has been absolutely fine. In the second trimester, you will start doing those USGs every 2 weekly to करेगा. ठीक है. Next slide. Third trimester, nothing significant. No history significant. Okay, next slide. Menarche, okay, fine. Next. Okay, next. Next. No, next slide. Next. By the way, we have posted the link for the feedback. It is very essential for us to know how you have felt about the session. So I've posted the link in the chat. I've pinned it. Kindly fill it and you will also receive the certificates on that. Okay, dietary history, fine. Next. Next. Significant directly examination में जा अभी. Okay. Examination में what are the differences between a singleton pregnancy का examination and your multifetal pregnancy का examination?
So firstly, the abdomen will be more over distended in the multifetal pregnancy. Then means multiple fetal parts are felt in means multifetal pregnancy, and distinguishing lie is more harder in multifetal pregnancy. Then there can be increased means the weight gain should be more increased in multifetal pregnancy.
Okay, very good.
Symphysis it will
Yes,
also not
continue.
symphysis fundal height will be more than the gestational age.
Okay, could you tell me what are the other reasons in which the symphysis fundal height is more than the gestational age?
So wrong dates is one of the reason. Then
Yes.
polyhydramnios can be the reason. Then
Okay.
fibroid in the uterus can be one reason.
Between multifetal pregnancy can be multifetal pregnancy.
Okay, what else?
A large baby such as macrosomia and that.
GDM can be one reason in the female.
Okay, correct. Barabar, macrosomia. Fine. The other side of it, causes of reduced fundal height less than POG.
Again, wrong dates is the first reason. Then IUGR can be one of the reason. Oligohydramnios,
Uteroplacental insufficiency.
Okay, correct. Very good. Fine. Now, could you just come to the next slide? Okay. So, what are the changes that you will see in the general examination?
blood pressure can be elevated due to preeclampsia.
Okay, blood pressure can be elevated, and supine hypotension is going to be much more severe in these patients. What about the respiratory rate?
Respiratory rate will also be elevated because there can be dyspnea in the patient because of the over distension of the abdomen.
Okay, very good. Fine. Next slide. Okay, next. Okay, next. Next. Okay. In your auscultation, you have, I think, not mentioned about the auscultation. Could you tell me what is the ideal technique for auscultation in twins? And by the way, we have posted a new link. Everyone, there's a new link. मेरे latest message में मैंने pin किया हुआ है. Kindly fill that form. There was an issue with the earlier one, so please fill that feedback form. It is essential for the attendance. Yeah. Tell me.
The fetal heart rate should be examined by the two persons simultaneously.
Yes, correct.
And there should be difference of 10 heartbeats, and the two heartbeats should be heard at a distance of more than 10 centimeters.
Yes, correct. Very good. So 10 centimeters apart, two different people hearing the FHS, and the difference between both the heart rate should be more than 10 beats per minute. That is how you would know that you are not listening to the same sound that is radiating from the same fetus, and you are looking at two different fetuses. What is the best way, though, to know whether both the fetuses are alive? Best way, gold standard.
On USG, there can be movement of fetus which can be detected. So it is
Very good. So could you just mention what are the uses of a USG in multifetal pregnancy? What all indications apart from complications? Anything else?
We can know the chorionicity of the placenta. We can know.
Yes, very good. Chorionicity. What is the ideal time to look for chorionicity?
Ideal time is 11 to 13 weeks. It can be best heard. It can be earliest by 7 weeks, but best is 11 to 13.
Okay. How do you differentiate between DCDA and MCDA?
In DCDA, there will be 4 membranes in between, and thickness of membranes should be more than 2 mm, and there will be lambda sign, and some there can be different sex of the twins also.
Okay, very good. How many layers are going to be seen in both the twins, between both the twins in DCDA and MCDA?
In DCDA, 4 membranes, and in MCDA, 2 membranes can be seen.
Okay, very good. And any difference between the length or the measurement between both of them?
2 mm, more than 2 mm should be present in the DCDA twin.
And less than 2 mm in MCDA. Okay.
MCDA.
What is the commonest complication that you will encounter in MCMA?
Cord entanglement.
Cord entanglement. Okay, fine. Now, in your patient, how do you intend to deliver this, or how do you intend to manage this patient henceforth?
As the pregnancy is suspected to be DCDA pregnancy, and hence it can be delivered after 37 weeks of gestation.
Very good.
We will do USG to know the presentation of the fetus set and then decide the further maneuver.
Okay, so if your first wear is in Kifal and the second is in breech, can you deliver it vaginally?
Yes.
Yes, we can deliver in vaginally if it first is cephal and second is breech. But it depends on situation. If there is any other contraindication for vaginal delivery, like placenta previa, or there is cord prolapse after rupture of membranes, then we have to deliver it through C-section.
Very good. So one very important complication is going to be cord prolapse. Now that I've mentioned about cord prolapse, could you mention how do you manage a cord prolapse?
We push the cord back if it is outside the vagina. We don't push it into the uterus. We can over distend the bladder with Foley's to move it up and then deliver
Okay.
it back to the
Okay, so imagine you're doing an artificial rupture of membranes and at that point of time the cord has come out, has prolapsed. What do you do next?
We can put a if a cord is present outside, we can prevent the vasoconstriction by minimal handling of the cord. And if it is outside, then we can put it in the vagina and we can prevent the excessive loss of amniotic fluid by putting a cloth or something. And then we can do foot in elevation and fill up with the Foley's catheter bladder to over distend it.
So very good. The first thing you do is call for help. Once help arrives, you do not remove your hand outside, because if you remove your hand, the entire cord will come out and your room temperature is between 20-25 degrees Celsius. That will lead to cord shrinking. That will lead to the constriction of the vessels inside the cord, and that will lead to fetal demise. So you keep your hand inside, till the LSAS is done and the fetus is delivered. You do not try to handle the cord, you just keep your hand there so that the cord doesn't fall out. You fill the bladder, your colleague fills the bladder, you don't do anything. Your work is only to keep the baby's cord where it was, and you elevate the foot end, of course, and you take the patient immediately for LSAS and you deliver it. Okay. Your second twin is, let us assume your pregnancy is preterm, just like your case, 35 weeks. Second twin is in breech. Vaginal karoge?
No, there are increased chances of head compression in breech section.
So do you have any way in which you can still do vaginal despite it being breech?
We can try external cephalic version in this
Are you
case.
sure it is ECV? Are you sure it is ECV? Or is it something else?
Means in transverse lie, we try internal podalic version, but
Very good. Even if it is breech, you can attempt, think of attempting IPV, that is internal podalic version. But a lot of people say that internal podalic version can lead to uterine rupture. So a lot of people don't prefer to give preterm breech, even if the second twin is in breech, they do not prefer to give it trial. वो directly cesarean करते हैं so that दोनों twins cesarean से निकल जाए. They do not try to attempt IPV because it can lead to uterine rupture as well as hand or foot prolapse or even cord prolapse. ठीक है. Okay. Any specific labor-related complication in monochorionic monoamniotic twins? Do you give them a trial of labor in first place?
as there are more chances of cord prolapse or entanglement, then we will prefer cesarean section in
Very
MCA.
good. What is lock jaw? Locking of jaw?
If first twin is breech
Yes.
and other twin is cephalic, then after coming of head and the cephalic end of the second twin can get interlocked. It is called an interlocking.
Yes. Very commonly seen in MCMA twins, interlocking of twins. Very good. So in your case, you or your patient is DCDA, you can wait till 37 weeks. When do you deliver MCDA twins?
At 36 weeks,
36 weeks. Okay. When do you deliver MCMA twins?
32 to 34 weeks by C-section.
Okay, very good. 30 to 34 weeks by cesarean section. Any role of corticosteroids? Someone has asked.
We will give corticosteroids means prior after 28 weeks of gestation.
Okay, very good. Because you are anyway anticipating possibility of preterm delivery, you will cover with a single dose of steroids, not anything more than that. Okay. Now there are a few questions that were asked by the audience. How do you balance the timely delivery versus risks of prematurity in twin or triplet pregnancies? So the answer is, of course, you'll be giving steroids, and with that, even if there is prematurity, I will ensure that the baby is not going to have respiratory distress or NEC or any of those complications. Um, One more question is, what are the most important maternal complications? We have already discussed them, and how does chronicity influence pregnancy? We have also discussed the complications of that. So I think that covers all the things. I have just a few last questions. If it's a triplet pregnancy, when do you deliver it? If the female has not decided to reduce it, when do you deliver a triplet pregnancy?
Sir, generally triplet pregnancy is delivered at 35 to 36 weeks after spontaneous labor.
Okay, very good. So around 30 to 32 weeks is when you deliver these babies, and it is of course by cesarean section. Great. Apart from that, could you tell me how do you deliver conjoined twins?
C-sections.
Yes, C-section, but is there anything differently that you do? If it's a term, third trimester wala conjoined twin.
So basically, sometimes conjoined twins are diagnosed at the time of labor, basically. So
Okay, so what do you do for them? What type of cesarean do you do? It is one of those rare indications for that type of cesarean.
lower segment, sorry, the
Oh,
classical cesarean section.
classical cesarean. So yes, conjoined twins, it is going to be very difficult to try to deliver it by your usual lower segment in a third trimester twin. Vaginal delivery तो is impossible. सिजेरियन सेक्शन भी क्लासिकल करना है बिकॉज अगर तुम लोग लोअर सेगमेंट से करने जाओगे तो दैट विल लीड टू बैड एक्सटेंशन इनटू द ब्रॉड लिगामेंट प्रोबेबली ब्लैडर को भी रप्चर हो जाएगा hence do a classical cesarean section for a third trimester conjoined twin. So that is it about this session. Darshan, Mohit, amazingly prepared. You were at par with the best of PGs that I might have taken vivas for or seen the vivas being taken in their MS exam. Amazingly answered and really well done, well read. So anybody, any doubts? Anybody has any doubt in the comment section? Kindly let us know. We'll be waiting for a minute. Until then, please fill the feedback form. We have posted it. The feedback form can be filled. We will require your feedback for the attendance as well. Apart from that, Darshan, Mohit, very well done.
Thank you, sir.
Thank you, sir.
Okay. So that is it from today's session. I think there are no more doubts. The next session is going to be on Saturday, and the session is going to be on anemia in pregnancy on 16th of August. Discordance versus FGR, we have already discussed. Discordant is basically just the baby is smaller, but there is no Doppler change that is seen. So it is basically the fetus grow ही कम हो रहा है because probably the placenta is small or the genetic potential of that baby is small. So that is the cause of discordance. So discordance के बहुत सारे cause होते हैं. SGR is a type of discordance, but with Doppler changes. So basically, there can be Doppler changes. There can be smaller placenta to one of the twins. या फिर एक ही placenta में एक placenta का जो sharing है, जितना percent placenta का मिलता है. Whenever there is monochorionic gestation, you get a certain percentage of placenta to both the twins. दोनों में 50-50 नहीं होता है. एक को 60% placenta जाता है, एक को 40 आता है, एक को 70 जा सकता है, दूसरे को 30 आता है. So unequal placental sharing might happen, or because both the babies are having completely different genetic potential, इसलिए एक बहुत बड़ा हो रहा है और एक normally छोटे तरह से grow रहा है, but both are normal. And the third possibility of discordance is if one of the twins has anomaly in it. So multiple causes of discordance. There's one question: why do we reduce fetus away from the cervix? Mohit, would you just want to answer it once again?
So basically, if we try to abort the fetus near the cervix, then it will cause premature activation of labor. So the body's main work is to remove the fetus. So it will try to remove the normal fetus also and the dead fetus also. So this will cause the termination of whole of the pregnancy. and not the selective one.
Okay, correct. Very good. So that is it, everyone. I've shared the feedback form link. And thank you so much, Mohit. Thank you so much, Darshan. That was really well done. So thank you so much, everyone, and good night. Kindly fill the feedback form. That is Dr. Aditya signing off. Thank you so much.
Thank you,
Good
sir,
night.
everyone.